Hello everybody, wherever you are in the world today. It's my great pleasure to have you with us for the third day of our webinar activities celebrating the Brain Awareness Week. I think the Brain Awareness Week is a very important issue in the sense that it tries to alert the world public to progress in brain research, but also to these aspects where we are not so good at the moment. Nevertheless, the World Federation of Neurorehabilitation certainly feels responsible to be involved in what we could call brain repair. The brain is an important and nevertheless a very vulnerable and very soft organ, which is apt to an awful lot of different injuries. Examples are stroke, traumatic brain injury, Parkinson's disease, other degenerative disorders, inflammatory disorders as multiple sclerosis, and many others. And what we are trying to do within this week is to report some information on how we can help to bring forward brain repair when it is necessary. Today is on rehabilitation after stroke with a special emphasis on technological aspects, which we blend in. And it's my delicate honor and pleasure to introduce our first speaker, which is Caterina Pistarini. She is the Secretary General of the World Federation Neurorehabilitation, involved in almost all of our activities in a very diligent and active way. She is for many years a leading expert in various fields of neurologic rehabilitation, spanning from disorders of consciousness all the way to stroke and others. And Caterina this afternoon is going to talk about rehabilitation after stroke. And nice to have you with us. And I think we have a pre-recorded video, Christian. Do you want to say some words in advance, Caterina?
Yes. Thank you so much for your kind introduction, and welcome to the attenders. We face to the important topic about the awareness of our brain, as we introduced 2 years ago, the Brain Awareness Week. And this topic is particularly addressed on the recovery of stroke with the use of advanced technologies. Me and my co-speaker, we face the important aspect and the advances in the use of technology in rehabilitation field. I think I am the first speaker, perhaps.
Yeah.
And
well, Christian, if you don't mind, you could start a video. Yeah, fine, here we are.
Thank you. Nice to meet you to this important event dedicated to brain awareness. Now we talk about the chance for stroke rehabilitation with the use of advanced technologies. As you well know, about 50% of population worldwide suffer from some form of disability. More than half of the burden in dailies is constituted by cerebrovascular disease, such as a stroke. These numbers are likely to increase in the coming year due to aging population, since disorder affecting people over 60 years contributed to 23% of total global burden disease. These are the results from WHO study in 2010 and published on Lancet in 2014. But we know that only 20% of patients fully recover their social life and job activity after stroke. And a traditional neurorehabilitation procedure could be limited in efficacy in most patients. Hence, there is the need to enhance and to maximize the functional outcome of patients as well as their quality of life. Modern technology represents a valid tool in the last years. And this is exiting because means that there are many opportunities to augment patients' rehabilitation. From big robotic machine to small wearable device, new technologies can help deliver different therapy goal in patient population within a different type of rehabilitation facilities. In this slide, you can see the application area of modern technologies. However, the choice of which technology to use can be overwhelming. Many robotic devices have been used in stroke patients, and in this slide you can see some example. The devices are dedicated in particular to the recovery of a proximal joint of the upper limbs. These are examples of the use of robotic machine in the recovery of a motor deficit in upper limb, and a minority to the recovery of distal joints. But also about a quarter of patients with the stroke outcome, 3 months after the acute event, are forced to use a wheelchair. In 60% of these, the quality of walk remains somewhat deficient compared to need request for a lifetime normal. It becomes obvious that we need also an intensive treatment for lower limb for reduce the 60% of patients. And in this slide, you can see some robot used for the recovery of gait and walking and stance. A study on a patient using robotic device at different stage of post-stroke rehabilitation highlight 3 different operating programs: passive movement, assistive modality, and resistive modality. And they can be used in different phases, in different stage of post-stroke rehabilitation: acute, subacute, and chronic phase. Robot device for rehabilitation differ widely in terms of mechanical design, number of degree of freedom, and control architecture. Type allow for intense high repetition therapy and differ in the interaction with the user. In this slide, you can see some examples, some work dedicated to the rehabilitation with robot device for the recovery of the upper limb and the lower limb in stroke patients. Then from all of this study, we can say that robot treatment can be useful for the recovery of motor and cognitive deficit, and treatment need to be patient specific. The key factors are the timing of intervention and method of intervention, and the results can be used for multi-center survey. There is a large opportunity also to apply robot therapy to remote treatment in personal environment of patients. And many subjective aims, for example, cognitive aspect related to participation, can be considered in the treatment with robotic device. And there are many perspectives for research. Now I would show you novel approach for the recovery of stroke patients. For example, non-invasive brain stimulation technique that can influence cortical excitability, neuroplasticity, and the behavior. Now we have more than 1,000 studies performed in human, and many of them are focused on stroke rehabilitation. In this slide, you can see an example of this non-invasive brain stimulation technique technique, transcranial magnetic stimulation, and transcranial direct stimulation. And several studies describe the use of non-invasive brain stimulation associated with conventional treatment and the improvement of therapeutic outcome. More recently, some small clinical trials have been developed and describe the associated use of non-invasive brain technique and robot therapy in stroke patients. Other tools for the recovery of motor and cognitive deficit in human post-stroke rehabilitation is the brain-computer interface. Depending on the technical aspect, one way or two way, the aim of a brain-computer interface is to command an external device with the intention born in our brain. Then this is a very interesting results nowadays applied only for research, and this strategy, this method, opened the door on the recovery of stroke, focusing the aspect of movement on the intention. And another strategy for the recovery of deficit, cognitive and motor deficit in patients in neurological disease and in particular in stroke is represented by virtual reality or immersive reality. Virtual reality technology has the ability to create an interactive environment where patients can provide personalized treatment. In this slide, you can see some example, such as in this one and in this one. The aim is to promote the recovery with the immersion of patients in natural environment, in his home or in his city or in his environment in general. And I would to conclude my presentation with a new reference model for treatment represented by telerehabilitation. Telerehabilitation is a very helpful tool to provide treatment after discharge of patients from hospital and to continue the treatment in the community and at home, of course. Information and communication technologies provide service and treatment in situations where patients and operator are not in the same place. And we have in rehabilitation some treatment that provide service with the support of new technologies. In this slide, you can see the practical example where a patient is at home and operator in hospital, and the operating modality of telerehab can be online and offline. It depends on the modality of performance of patients. In offline modality, patient teach the exercise and execute the exercise by himself at home, and in a second time, operator control, monitor the results. In the online modality, the operator monitor the exercise performed in the same time by patients at home. These treatments are addressed for the recovery of motor, cognitive, and speech deficit in post-stroke patients. And in this slide, you can see the theoretical architecture of the system. Cognitive and motor exercise performed by patients are results in some performance, and the performance of patients is sent into central server size that can be located in hospital, for example. Then central server size in hospital is the store of the results of performance of patients, and the results can be examined in a second time. This telerehabilitation strategy increase treatment compliance, enhance the frequency and intensity of rehabilitation protocol, and increase adherence and motivation of patients. But during the exercise or after them, we can also to monitor the clinical status of patients. For example, in this slide, you can see that the system of telerehabilitation can be used for monitor the tremor of upper limb of a patient. This can happen in stroke patients, but also in other neurological diseases, such as Parkinson's disease also. In the last year, the use of telerehabilitation increased, as you can see in this histogram, but in this graph, in this picture, and the data from literature increase in the last time. For example, as you can see, in 2 years, the number of work about the use of telerehabilitation in our setting, neurorehabilitation setting, is increased in respect of the previous year. And we have undoubtedly some advantages with the use of telerehab. The study demonstrated that the results with standard treatment and telerehab treatment are similar, and with the telerehab, different type of treatment can be provided. The efficacy seemed to be linked of type and not from the modality of treatment. Low familiarity on computer use is not an obstacle for telerehabilitation. Acceptance and satisfaction of patients is good. And telerehab is the method used with smart solution. Smart solution guarantee a continuous and coherent relationship from in-hospital setting to domestic environment in a supervised way. And this solution have been adapted in particular situation. For example, during the COVID pandemic, or can be used in a specific situation. The solution personalized treatment via telephone or live internet connection or via pre-recorded session. In some countries well developed, secure virtual care platform already exist. In other, media such as Zoom, Skype, FaceTime, and other may be suitable alternative. However, it is helpful to take in mind that there can be some limitation on the use of smart solution due to technical malfunctioning or ready availability of equipment. In this slide, I show you the evolution of these technologies, and now we are able to provide, as I said before, treatment with a very small tool, phone, a smartphone, or PC or tablet, and so. And I would also to show you this solution adapted during COVID pandemic in our rehabilitation setting for domestic rehabilitation. Patients at home perform the exercise displayed on the monitor of TV, and the exercise are stored in an entered SIM card, and the exercise performed by patients are recorded by a webcam sent to external cloud and to operator who stay in clinics. This exercise can be addressed to cognitive and motor deficit in stroke patients, in traumatic brain injury patients, and can be monitored by operator with the modality online or offline. This experience can be developed. We consider that delivering interdisciplinary rehabilitation that is initiated early in hospital stay must be continued, in particular in chronic disease at home. And this also permit to have a safe and restorative management, as you can see with the smart solution, and continuing management and disability specific intervention during a specific period for an individual with chronic disability, avoid social isolation, lifestyle changes, and psychological stressor that may result in new or worsened issues. Rebuild and implementation. Our neurorehabilitation activity is a unique challenge for offering new possibility for neurorehabilitation treatment. And for the future, we should rethink within WFNR how organize the link between hospital and home rehabilitation for maintaining greater quality, adherence, and effectiveness of our treatment for patients who need. Thank you very much for your attention.
Okay, Caterina, thank you very much for this very nice review on some, let's say, aspects of technological advances we had over the last decade or so, which may be helpful in bringing neurorehabilitation forward. Let me look if we have questions from the audience. To the audience, it's good if you ask questions on the question answer section easily. At the moment, I don't see any. Nevertheless, let me ask one question to Caterina. I mentioned that very often, that it's always nice to look at high-tech options for neurorehabilitation. But I think, on the other hand, it's also important to emphasize that we can do quite good neurorehabilitation even without using high technology, which is important for many parts of the world. On the other hand, what you mentioned, Caterina, is the use of, let's say, communication strategies, digital communication strategies, telemedical approaches, which may help us in future very much than we did before to convey information about skills and procedures to much larger audiences and affected people, caregivers, relatives, and so forth around the world, which I think definitely will open new windows for us and also for WFNR, new windows to bring this forward. We are just setting up a task force within WFNR to find spots around the world, where we have 6 or 7 or more in various countries, to develop this further by teaching activities as well, and other educational activities. And that certainly telemedical approaches and let's say digital communication technology will certainly blend in. I'm happy that our friend Nomal Surya is with us at the moment.
Yes.
And yeah, can't see Nomal at the moment. Oh, there he is. Welcome, Nomal. Okay, any question from your side?
So I was just asking Catherine, I put up a question. Do you think that this new technology which is coming, including the human robot, are they going to change the therapy, the way the rehabilitation services will be practiced in next 10 to 20 years?
Yes, Nirma, good question. I think that after many years, 20 years ago, we started with the robot therapy, in particular for the recovery of upper limb, because the upper limb recover very late in respect to the lower limbs, in particular in stroke, because stroke is the main field for our investigation. And robot, we have a lot of robot. Robot is particularly helpful to enhance rehabilitation during the hospital stay. Because for practical problem and economic problem, do you know? Smart solutions are a new tool, and is very easy because open the door to the enlarge the solution in patients without the hospitalization. And for all the patients who need to continue rehabilitation, in particular cognitive rehabilitation, but also motor exercise or other, is very helpful to provide a list of exercise for patients, and the patient can perform the exercise at home. This avoid the hospitalization, can be performed at in any time when patient is at home. Don't need the supervisor, and then caregiver can help the patients in a minor way, and patients can go to visit after a period of time. The telemonitoring is very easy. Now, in the recent evolution of information technologies, we can use the smart solution. Smart is a very good term to define the telerehab. We can use for our treatment, in particular in chronic condition.
Thanks, Katerina. Let me look at what questions we have. There's one from Linda Crawford, and she's wondering about our thoughts on linking research better with clinical services so that clinicians may have more time and support to contribute to research.
Yes, this is a wearable device are used in the past in our setting. Was a t-shirt with some electrode, and this method has been used in a European project some years ago for neurological patients for the recovery of upper limb.
Yeah, well, there was another question.
Very expensive. It is very expensive technique.
Well, coming back to that original question, I think it would really be desirable that people working with patients are more involved into research as well. That is often difficult, depending on the institutions you work in. I come back to an old statement which Barbara Wilson made about 25 years ago. So, stating that every patient is an experiment in himself, of course, and you could do in actual fact, a lot of work, even outside organized trials, in observing patients and doing one case study. And that can be extremely informative. And more and more, with all the Cochranian philosophy behind it, it's more and more neglected. But nevertheless, it's still a very valuable and reasonable source of information. And to say that to everyone who's involved in that, observing the patient and doing, in some sense, experiments with patients can be extremely informative for bringing.
Yes, this is an important aspect, the collection of data and the management of data to find the best solution. Wearable solutions are very expensive, and as you said before, it is an agreement between user and provider to have the wearable solution. It's very expensive. In our experience, the stop has been the economic aspect of the solution.
Yeah, well, that is certainly true that there are economic obstacles in using technology. That is nevertheless, by and large, melting more and more in the sense that technology become better available, become cheaper, and the number of let's say specimens are increasing. All of that makes that, of course, cheaper. But wearables can be very helpful for gathering data on patients, especially on this telecommunication type of monitoring and activities. Nirmal, any comment from your side?
No, thank you very much. Your comment has been absolutely to the point.
Okay, let me just say a brief word about robots. You know, we have been playing with robots for more than 20 years. And robots are nice, very nice to have, and can be helpful opening new therapeutic windows, in particular patient populations, especially severely gait impaired patients, as an example.
Yeah.
But you can do, the robots are certainly helpful, but the robots are not all of it. And by and large, robots are pretty dumb machines, to be honest.
It is true. And respecting to the first robot, very heavy, very very particular for upper and lower limb. Now, for lower limb, in particular for spinal cord injury patients, we have a smart solution, very smart for the recovery of a gait. And without the name of the product, but it is very important.
But okay, I can very much see that in next 10 years time, there would be a human robot, which will be with the artificial intelligence, will come and tell the patient, okay, you got neck pain, you need to do these exercises, turn your neck to the right, turn your neck to the left, do this. Similarly for the back, because this would be possible so that somebody don't have to even go. So they have the robot at home and who will guide them, do the exercises. I can see that this will be possible. There may be centers where these robots would be there. Somebody has neck pain or back pain or the stiffness in the shoulder or the back. They'll go to them and they will guide them. So maybe the therapist requirement could change in next coming years. This is what I could see. It may not be available to everyone, but I can see that we are progressing towards that.
Now, there's another question how we can promote technology in neuro rehab in low middle income countries. That is certainly a very important, it's one of the key issues WFNR is addressing very intensively at the moment, and we will certainly within the next 2 years have a much better and more straightforward concept in doing this. I always like to mention this, that during this pandemic, the best thing we have learned really is to use digital technologies with more ease than we did before. And that is certainly of great hope. And there's another question by Sanatchin is, let me see, I don't know if I understand that correctly.
Whether
tell us if level-wise use modules in languages spoke across globe can be validated, developed, posted. Well, we try. We recently did that with a long COVID helping app and things like that to make that available in many languages. This is not a real problem anymore. We have coders around the world. You can help us with that, and that we certainly will go forward with this multilingual approach.
Yeah.
Which is important, definitely, to do it. And you know, smartphones are present everywhere, and tablets are present everywhere, much more than robots are present everywhere. And of course, we have to use these sources of technology much more. MSCF-based symptomatic intervention models. Well, I don't want to go into that. I think the ICF that's a never-ending story. All of us are using ICF terminology. ICF is a nice language, but especially it's a language to describe, let's say, services around the world and to compare services around the world. It's not a good language when it comes to individual patient need, because patients do not understand ICF. That's the problem. Okay, so if there are, Nirmal, any comment from your side?
No, sir. Thank you very much.
Okay, so then I think we can proceed. And our next speaker is Professor Namjong Paik from Seoul in South Korea. He is the incoming president of the World Federation of Rehabilitation, and a very, very, very experienced person in the field, especially of neuromodulation, with an enormous track record in this respect. Unfortunately, I was informed earlier today that he will not be able to join us today for some problems he has to address, which are very important in his family. And we have, of course, to respect that, and we wish all the best to how this is going to develop. So I think, Christian, we have a video from Namjong, and we play that. Okay.
Good day, everyone. I'm Dr. Nam Jong-baek, the president-elect of the WFNR. Today, we'll be discussing the topic of rehabilitation after stroke, how technology blends in. Stroke is one of the leading causes of long-term disability worldwide, with a significant impact on an individual's physical, psychological, and social well-being. Stroke rehab is an essential process for individuals who have had a stroke, with the goal of maximizing their functional abilities, promoting independence, and improving their quality of life. Over the years, rehabilitation after stroke has evolved with the integration of technology into traditional rehabilitation methods. In this lecture, we'll explore the various technological advancements in stroke rehabilitation and how they have improved outcomes for individuals after a stroke. One of the most significant technological advancements in stroke rehab is the use of robotics. Robotics has been introduced in the stroke rehab to improve the motor function of individuals with a stroke. Robotic devices can assist in training and retraining of the affected limb, improve motor coordination and strength, and reduce spasticity. Robotic devices such as exoskeletons and effectors and robotic arms are used to assist the patient in performing daily activities and exercises. There are many types of rehabilitation robots: lower limb robot and upper limb robot, exoskeletal type or end effector type, tethered system or non-tethered system. Advantages of robotic rehabilitation is it provides high-intensive, repetitive, task-oriented, and task-specific training with high precision and endurance, and it can be standardized and has motivated training context and provides real-time feedback and is adjustable. It is appropriate for all levels of ability, and it may be cost-effective depending on manpower cost and reimbursement system. I think this is important milestones of rehab robots in clinical practice. Rockmart started their service since 1999 and got FDA approval in 2002 as Class 2. InMotion for upper limb and Rework for spinal cord injury got FDA approval in 2012 and 2014. Recently, in 2019, Restore for stroke obtained FDA approval. Recently, in 2019, a versatile portable exosuit that assists hip extension was introduced in journal Science, and it has shown that metabolic rate of walking and running was reduced wearing this exosuit. The exosuit automatically switches between actuation profiles for both gaits on the basis of estimated potential energy fluctuations of the wearer's center of mass. Reduction magnitudes are comparable to the effects of taking off 7.4 and 5.7 kilograms during walking and running. This soft exosuit may have implication on athletic performance changes and also patient gait performance who has neurologic impairment. We developed the soft wearable robotic AFO for stroke patients. Ankle braces was flexible and 3D printing was used. For easy on and off, hook and loop fastener were used. Actuation mode was designed to move bidirectionally to assist ankle dorsiflexion and also plantar flexion. And it had a gait sensing module, and gait cycle could be detected in real time. Gait analysis was done without AF4 and with AF4. In the walking experiment in a post-stroke patient, both gait proportion as well as foot drop prevention of paralytic side was improved as you see in the right above figure. Gauge symmetry was also improved in the right lower figure. We designed this study to investigate whether the teleassessment of elbow function, such as passive ROM, muscle strength, spasticity, is feasible using master and slave robot in patients with stroke. To implement the telerobotic system for remote assessment, we constituted a master robot interacting with the doctor and a slave robot interacting with the elbow in a subject with stroke. The communication of current position and force information of the master and slave robot was implemented by a custom-built software using public internet. An intercontinental remote assessment, which was one of the worst scenarios, was designed as a clinical test to check feasibility. For the clinical test, stroke patients with unilateral upper limb hemiparesis were recruited. The examiner for the teleassessment was located at the lab in Maryland, United States, and stroke patients were located at our clinic located in South Korea. The assessor at remote area used the master robot and instructed the patient wearing a slave robot to do an appropriate action by using video conferencing. Through the manipulation of master robot, the remote assessor felt the resistance of the elbow of the patient. There are many kinds of care robots. Examples of robotic devices physically support old personal caregiver or robots helping old people in physical and everyday tasks are transfer robots, shower-assisted robots, meal assist robot, soil prevention robot, toileting assist robot, and etc. There are also social robots interacting with humans using an artificial intelligence system. Another technological advancement in stroke rehab is the use of virtual reality. Virtual reality is an innovative technology that creates a simulated environment that provides a sensory experience to the user. In stroke rehab, virtual reality can be used to provide patients with the real-life experience of performing everyday tasks. Virtual reality can be used to improve upper and lower limb function, balance, and coordination, and can be customized to suit individual patient needs. Rehabilitation using virtual reality has many advantages. It is immersive, closely resembles real-world setting, and provides observational learning and augmented real-time feedback. It has physical as well as cognitive components and is adjustable and can be standardized and enables remote care. The box and block test is a conventional, simple, and easy-to-apply assessment tool that is frequently used in hospitals, and previous studies has demonstrated its usefulness in stroke rehabilitation. Here, using a conventional depth sensing camera, we developed the virtual box and block test system for later use for assessment of patient function in telerehab setting. Such a virtual upper limb function assessment tool that can be implemented in a home setting could be a key component in a home-based virtual rehab system. Comparison results between the real and virtual box and block test showed high correlation and possibility for virtualizing conventional and unsupervised assessment. This time, we developed the Fugel-Meyer assessment tool using KidNEC and validate it for hemiplegic stroke patient. The FMA has been used as a gold standard of measurement of impairment in patients with stroke. If it could be measured automatically and unsupervised at home, it may be very useful for monitoring patient function and progress in tele-rehab setting. In this study, 41 patients with hemiplegic stroke were enrolled. 13 out of 33 items were selected for upper extremity motor FMA. One occupational therapist assessed the motor FMA score while recording upper extremity motion with KidNEC. FMA score was calculated using principal component analysis and artificial neural network learning from the saved motion data. Prediction accuracy for each of items and correlation between real FMA score and score using KidNEC were analyzed. And correlations were very high, and we found that FMA using KidNEC is a valid way to assess upper extremity function, and this method may be useful in the setting of unsupervised home-based rehab. Hemispatial neglect is a common impairment of stroke. It is associated with poor functional and social outcomes. Prism adaptation therapy is one of the most evidence-based rehab modality to treat hemispatial neglect. We developed a system using immersive VR and in-depth sensing camera to create virtual prism adaptation therapy. Left side is a picture performing usual conventional virtual adaptation therapy. To validate this system, we designed an experimental protocol investigating the behavioral errors using this system. Training included repetitive pointing. Patients' behavioral data showed that patients adapt to virtual prism. The preliminary result from healthy participants showed that pointing errors by this system was similar to the conventional prism adaptation therapy. On the conventional passive treadmill that runs at a constant speed, the level of patient engagement decreased than the conventional gait training on the ground, and so might be the cortical activity. On the right video clip, to increase the level of cognitive engagement and brain activity during gait training, we developed a self-paced active treadmill to allow patients to change walking speed based on their intention in a similar way to the level ground walking. Left video clip showed an curved treadmill training based on patients' intention to change the direction of gait using depth sensing camera. To validate the effect of the active treadmill training on increasing the cortical activity, we measured EEG and FNIR signal at the prefrontal cortex, supplemental motor area, and primary motor cortex during target speed walking according to speed displayed on monitor in patient with ischemic stroke. As you see here, patients showed higher brain activities, meaning increased cognitive engagement in the prefrontal cortex assessed by FNIRS. In EEG, increased spectral power of the low gamma and beta band were observed in prefrontal cortex, supplementary motor area, and primary motor cortex, which implies that patients paid more efforts to plan their movement, including swing speed and timing of heel strike. We also measured gait asymmetry during slow and fast walking between the passive and active treadmill walking task. Patients showed reduced gait asymmetry during active treadmill walking task, especially patients who showed greater gait asymmetry initially. Based on our findings, self-paced treadmill walking system has the potential to enhance cortical activity and neuroplasticity and to increase the effect of treadmill gait training in patients with stroke. This picture shows merged system with virtual reality and TDCS that we are developing. Combining task-oriented training using VR and TDCS can increase the neuroplasticity and hence better motor recovery. Patients with brain injury can use this system in the hospital setting with the supervision of clinician and then can continue to use it at their home with telemonitored system. Technologically, combination of imaging-based modeling or simultaneous brain signal monitoring with TDCS could result in better individualized optimal targeting, allowing a more favorable neuroplasticity after brain injury. Depending on patient signal, TDCS dose or electrode montage could be adjusted on real time. For example, if patient is less attentive during VR training, system can adjust TDCS dose to higher stimulation or change TDCS electrode montage to stimulate attention-related brain region. Telemedicine is another technological advancement that has revolutionized stroke rehabilitation. Telemedicine allows for remote consultation with physicians and therapists, reducing the need for patients to travel to medical facilities. Telemedicine has made it easier for patients to access rehabilitation services and allows for more frequent interactions with healthcare professionals. Telemedicine can also be used to provide patient education, such as videos or online tutorials, which can be accessed from the comfort of the patient's home. Mobile applications have also been introduced in stroke rehab. Mobile applications can be used to monitor and track patient progress, provide exercises and rehabilitation programs, and provide patients with educational resources. Mobile applications can be accessed from smartphones and tablets, making it easier for patients to engage in rehabilitation exercises and track their progress. This is a typical platform for tele-rehab. First, patient can be assessed remotely. Assessment might be synchronous real-time or asynchronous stored and forwarded, or just telemonitored using internet devices or mobile devices. Then patient's assessment data is transferred to central DV. In central DV, decision support system using preset algorithm or artificial intelligence is operated. An automatic rehab program appropriate to the patient level of function is provided by automated messages or SMS. All this process is directed by healthcare provider by video conferencing. During this process, patients can enjoy serious games and gamified applications. Examples of gamification elements are points, badges, leaderboards, clear goals, challenges, labels, progress, feedback, rewards, stories, or themes. This brings more fun and more compliance from the patient and increases patient engagement. Within this platform, online support groups or chatbot or conversational AIs such as Alexa, Siri, Google Home can be built. This platform needs less supervision from the healthcare provider, is low cost, and provides easy accessibility. We developed a valid, reliable mobile aphasia screening test for patients with stroke in remote locations. Korean shortened version of the Frankai aphasia screening test was designed as an iPad application. We enrolled patients with and without post-stroke aphasia. To validate the mobile version, we compared its performance with that of Korean version of Western aphasia battery and conventional paper version. And we found that this method was reliable, sensitive, and showed a good accuracy. This means that aphasia test could be run automatically over the iPad. Then we enrolled 8 patients with chronic post-stroke aphasia to receive speech therapy using our iPad-based tele-rehab program. As you know, intensive speech therapy improves language function in patients with aphasia. Unfortunately, some patients with stroke go untreated due to socioeconomic problems. This study was performed to test feasibility and efficacy of the speech therapy-based tele-rehab program. Participants received 4 weeks of tele-speech therapy using iPad, which generates 6 domains with 6 levels of difficulty. We compared pre- and post-treatment scores of the Western aphasia battery to evaluate effectiveness. After the 4-week treatment, language function was improved significantly. The improvement was persistent at the 1-month follow-up visit. The degree of improvement was strongly associated with usage time regardless of patient age and severity of aphasia. Overall satisfaction with iPad use was high. The results shows that tele-aphasia therapy is an effective and feasible treatment method for chronic aphasia. There are also tools to evaluate cognitive functions. PASCO is such an example. It is an open software application for cognitive evaluation and stimulation, and consisted of visual attention, working memory, and planning tests. Lute Perez et al. Tested standard pen and pencil test versus software PASCO in 36 elderly people in the community and found that moderate concurrent validity between two tests. Smartphones appears to be an obvious choice for the development of easily accessible assessment tools for telerehabilitation. Bluilet et al. Assessed the feasibility, reliability, and validity of a smartphone-based application for the assessment of cognitive function in the elderly. A total of 57 non-demented elderly individuals were administered a newly developed smartphone application-based color shape test in order to determine its utility in measuring cognitive process speed in the elderly and demonstrate that scores on this test were significantly correlated with some cognitive tests such as mini mental state exam, digital span and trail making test, and digital symbol test. Virtual reality is one of popular tools which can be deployed for telerehab. VR has potential to provide intensive, repetitive, and task-oriented training, and game-based therapy can enhance patients' motivation and enjoyment. We designed this study to prove the efficacy of the low-cost Kinect-based VR system for upper limb recovery among patients with subacute stroke. We designed arm, elbow, wrist, and finger exercises. A double-blind, randomized, sham-controlled trial was performed. A total 23 subjects with subacute stroke were allocated to sham or real VR therapy group. Both groups participate in a daily 30-minute session of OT for upper limb recovery for 10 consecutive days. Subjects received an additional daily 30 minutes Kinect-based therapy or sham VR mainly consisted of cognitive training. Assessment was performed before the VR, immediately, and 1 month after the last session of the VR. FMA were measured, and also accelerometer were also used to measure hemiparetic upper limb movement during the therapy. FMA immediately after last VR session was not different between two groups. Significant differences of total activity counts were found in hemiparetic upper limb during the therapy between groups. And real VR group showed significantly more total activity count compared with the sham VR. But there was no statistical significance between real and control group, who received time-matched conventional OT. This study suggested that compliance in VR was good, and VR system induced more arm motion than control, and similar activity compared with the conventional therapy. Mobile devices such as smartphones and tablet PCs can provide personalized home-based therapy with interactive communications between patients and clinicians. In this study, a mobile virtual reality upper limb rehab program using game applications was developed for patients with stroke, and we evaluated the feasibility and effectiveness of the program. This randomized, double-blind controlled trial included 24 patients with ischemic stroke. The intervention group received 30 minutes of conventional OT plus 30 minutes of mobile upper limb exercise using smartphone and tablet PC. The controls received conventional OT alone for 1 hour per day. Rehab consisted of total 10 sessions of therapy. A greater improvement in FMA, brainstorm stage, and muscle power was found after treatment with the mobile therapy than with the conventional therapy. Patients in the experimental group completed the 2 weeks treatment without any adverse effect, and they were generally satisfied with the mobile therapy. We are running a protocol for randomized trial of home-based tele-rehab using smart wearable device with FES component for patient after ACL reconstruction surgery. We'll compare 6-week home-based rehab program that has game component with self-exercise control group. As you know, wearable technology is the next big thing. Promoting physical activity is important for medical and functional recovery after stroke. Therefore, an accurate and convenient measurement of physical activity is necessary to provide feedback on functional status and effects of rehab interventions. We assessed feasibility, reliability, and validity of the wearing accelerometer to monitor physical activity of stroke patient by estimating energy expenditures. This was a prospective, observational, quantitative study conducted in an inpatient rehab unit. 24 patients with subacute stroke were enrolled. They wore accelerometer on wrist and ankles for 3 consecutive weekdays.
The feasibility was evaluated by daily wear time. The 3-day accelerometer recording showed an excellent test-retest reliability, and accelerometers showed high correlation with direct observation. This wearing accelerometer may be used for measuring physical activities in subject at stroke unit and at inpatient rehab unit and at home. In terms of efficacy of telerehab, Dr. Kramer et al. Performed RCT to answer whether those a 6-week course of intensive home-based telerehab targeting arm movement after stroke provide rehab benefit that are comparable with those derived from those matched traditional in-clinic rehab therapy. Total 124 post-stroke patients received 36 sessions of dose-matched arm motor therapy plus stroke education. In this randomized, assessor-blinded, non-inferiority clinical trial, telerehab showed comparable efficacy to traditional in-clinic rehab for improving motor status and for improving patient knowledge about stroke. Meaning of this study result is that telehealth is an effective means to provide rehab therapy and improve patient outcome after stroke and may be useful for improving access to rehab therapy. This study demonstrated comparable evidence of telerehab over in-clinic rehab. Telerehab is a useful tool to provide patient-centered care, especially incorporating patient portal, patient health record, or patient diary function can allow patients engagement, patient-centered care, and promotes coordination between health professionals. Patient portals offer access to the patient to one or more of the following: EMR data, test result, printing or export of the portal data, medication refills, appointment scheduling, procure referrals, access to general medical information such as guidelines, and creation of secure messaging between the patient and the hospital. This June, the US FDA just approved the first prescription video game for kids with ADHD. Endeavor RX is the first video game that can be legally be marketed and prescribed as medicine in the United States. Now, a prescription video game is a real thing. It's not in the future anymore. Telerehab is one of digital therapeutics, and it will be expanded further. Now, precision rehab is an emerging approach for rehab that takes into account individual variability in genes, environment, and lifestyle for each person. This approach will allow doctors to predict more accurately which rehab strategies for a particular disease will work in which groups of people. All this genomic data, lifelog data, clinical data, patient-generated health data can be integrated into telerehab.
In conclusion, technological advancement have significantly improved the rehabilitation process after stroke. The integration of technology into traditional rehabilitation method has improved outcomes for individuals after a stroke. Robotic devices, virtual reality, telemedicine, and mobile applications are just a few examples of how technology blends into stroke rehabilitation. With the continued advancement of technology, we can expect further improvement in the rehabilitation process, making it easier for individuals to recover from a stroke and achieve their goals of maximal functional abilities, promoting independence, and improving their quality of life. Thank you for listening, and I hope you find this lecture informative.
Okay, so we all thank our dear friend Nam John for this really excellent tour d'horizon through all the many incoming and also already available aspects of neurotechnology. Questions from the panel? Katarina, Nomo?
I am I am surprised for the technology and for the organization of technology in the talk of Nan Yong. It is very attractive. The video and the experiment in the use of robot therapy. As you can see in the presentation, the robot help also person in everyday life without any specific neurological condition, but in a specific condition where our performance, walking or dexterity of movement is impaired. This opened the door to the use of technology in our aging population, and this is very important to consider.
Nomo?
I think it is a very exciting time. The kind of innovation to help the people with disability post-stroke has been amazing. And I think in coming few years, it will only get better and better. With an idea is helping those people who are living alone or who get a stroke with no support, old people living together. I think this home-based therapy and robot therapy would be a boon. And maybe in coming years, the people who could afford but have no resources or cannot have people around would be benefited by this new technology. I think there will be more and more things to come in next few years' time.
It's certainly right. Let me put a little bit of a bitter into the cocktail for the time being, though. Well, I think, yeah. Well, forgive me for that, but well, the point is, I look at Stephen Kramer's data on the data rehabilitation in comparison to inpatient rehabilitation. That all of this is fine as long as you're not dealing with severely affected patients. I think that has to be taken into account. These telemetrical approaches are nice in people who can move, and you can use motor learning rules to bring them forward. They certainly fail when you're dealing with patients who have a completely paralyzed limb, for instance. It doesn't work. And that is certainly another problem, that we do not yet have real technological means to improve impairment-oriented rehabilitation. So the second bit of bitter into that is we're talking a lot about virtual reality. And I think we have to be certain that not all of this, what has been shown also by Dan John, is virtual reality in the strict sense. Virtual reality in the strict sense is really a completely emerging. And most of this is just computer facilitated augmented reality work, and that is certainly a difference. We are at the moment working out is there is a difference really between VR and AR in affecting the brain. And we just completed days ago. We completed an MRI study on this, and in actual fact, we didn't find very much of a difference between emerging three-dimensional and two-dimensional AR. We have to work further on this. On the other side, I think it's very important, Ned, that all these immersive VR stuff is very nice, to increase the motivation of patients, because it's much more fun if you do that. And the motivational aspect, which has been neglected, in my opinion, for a long time, in the course and in the strategies, marketing, treatments, and rehabilitation, has to be addressed much more. But I think we are in actual fact, I agree that we are living in a very interesting time, and technology will certainly help us to improve what we can do. And fortunately, it's getting affordable more and more. And as I mentioned, I think for communication, I think it's a very important tool. Let me have a look at the chat room or the frequent answer. Well, there was a question in how far we can use fMRI to be integrated with neurorehabilitation in the present or in future. That is a very intriguing question, of course. And Katharina, do you want to answer that?
Yes, about the functional MRI. We are in the born of the technology because we have to apply some protocols of fMRI for understanding the ability of the brain to respond. We use fMRI at rest and after command, simple command, in patients with disorders of consciousness and with deficit of upper limb. But the results are initial results, and we have to establish some protocol because we have not definitive results.
Yeah, well, I think it's really an intriguing question, and of course, let's say imaging biomarkers derived from functional magnetic resonance imaging or other functional imaging techniques, maybe EEG, MEG, or whatever, is certainly intriguing.
Yeah,
so
it's very interesting too.
So far, nevertheless, it's very difficult to sort out which of these biomarkers really have a causal relationship in a logical sense to what we're doing. Yes. Certainly much more work is needed. And we were talking a lot of personalized, individualized medicine and these aspects, which I think is very important. But to be honest, also when it comes to the genetic aspects and even when it comes to, let's say, clinical biomarkers, we are not really absolutely certain in this respect. And that opens another question. And I notoriously insist on that. It's very difficult to say if you have a set of data and you say, well, this gives you a good or bad prognosis of a patient. Is this 100% true or not? And that necessarily invokes an ethical question. If you have a certain set of biomarkers that this patient, no therapy doesn't make sense at all, is this acceptable or not? And we certainly have to struggle around with this in future in much more detail as more biomarkers become available, which I think certainly is very good. And it's also good to find out responders and non-responders, to avoid useless treatments, and eventually to save money for useless treatments and invest money into more useful treatments. That's for sure. Okay, let me go back to the frequent answer room. As far as I can see, at the moment, there are no further questions. Katharina, final comment?
Final comment is it is very interesting that from the first robot therapy with the robot machine in the hospital, we arrive at the moment that modern technology expanded and we use in more and more the technology in our rehabilitation setting. But don't lose the work of physician, of therapist, and the clinical examination. This is important.
will remain important to some sense, right? But we we
It
have
remains important. Yes.
more open-minded, of course, for all these technology, which it's blending in, and that is very useful and can be extremely helpful, for sure. Okay, so if there are no further questions, well, no. Thanks all the speakers, thank the audience for their participation. Let me express my gratitude again to our dear friend Christian, who is working on the backstage of all the broadcasting. Thank you very much, Christian, and your team for helping us for the technological aspects of these webinars. We will have the next webinar tomorrow, the same time. That will be devoted to strategies in low-middle income countries, and with Namal Surya, who you have seen already, and Mayowa Walabi from Nigeria as the speakers. So hope to see you tomorrow again in good shape.
See you.
Yes.
Thank you very much.
Okay, bye-bye.
Thank you, Christian.
Katarina, we meet in about 30 minutes, right?
Yes, yes, yes.
Okay.
Thank you.
Bye.
Have a good day.
Thank you, Christian.
Have a good day.
Bye-bye.